A very good morning to everyone. This is your neurologist, Dr. Manish Mahajan, and this is 9th May 2022, and we are here in this wonderful morning discussing multiple sclerosis further on. And today I'm gonna talk about the disease modifying therapies. So I had already given you an overview why DMTs are required, what is the concept of no evidence of disease activity, that is NEDA, and what are called as the pyramid up approach and pyramid down approach. And today I'll slightly dwell in detail on that concept and enumerate the various disease modifying therapies with probably the common things which we need to look at when one is on disease modifying therapies. And maybe further in the series I'll also discuss about highly active MS, subgroup of RRMS, who acquire disability both physical and cognitive very rapidly as compared to the others with RRMS, and despite one or more effective disease modifying therapy. So, and we will discuss the laid down criteria for highly active MS maybe further on in the upcoming series. So starting with the disease modifying therapies, and so there are two schools of thought. One school is a old school which believe that one should always apply the pyramid up approach, that is starting with the platform therapies, but we say the tier 1 therapies, that is the bottom of the pyramid, and then escalate according to the requirement and when the disease behaves aggressively. And so the problem with this approach is that we don't have the factors yet known which can guide us who's going to behave aggressively and whose disease is going to be mild and would be staying okay on the platform therapies. But one thing I want to reiterate, that the current understanding definitely states all the people with RRMS should be on one or the other effective disease modifying therapy. Now the factors which usually guide us to take into account which DMT to be chosen is definitely the first and the foremost is the disease activity. So how the disease has behaved in the last 1 year is the most important factor which is to be taken into account before we put the basket forth to the person with MS and the caregivers. Other factors is definitely the gender, childbearing potential, age, and the cost is one of the very important limiting factor, as most of the DMTs, and especially in Indian scenario, the people have to bear the cost from their pocket, and most of the DMTs are really costly, and so we have to have adopt an approach where we have to strike a balance between the cost of the disease modifying therapy and the things which they can afford. One, they are costly. Second, they are required for a longer period of time. And secondly, the effect of multiple sclerosis on ambulation and cognition and further impacting their employment. So we, as the neurologist and MS physician, have a responsibility to take care of those aspects also, and to reduce that financial burden on people with MS. So as I have already said, that this initiation of the disease modifying therapy and selection of disease modifying therapy is a shared decision, but definitely we can't compromise on one single front, that is the disease activity, and because that's the sole motto of utilizing disease modifying therapy. So what are the platform therapies? If we talk about first the pyramid approach, usually the platform therapies include glatiramer acetate, which is a subcutaneous daily injection, and we have various types of interferons, beta interferons. Few are high dose, high frequency, some are thrice weekly, others are once weekly intramuscular, other ones are subcutaneous. We have intramuscular weekly interferons and even pegylated interferons, which can be given fortnightly. And the other usual things which we can give in the initial phase is an oral teriflunomide, which is a once daily oral tablet. Now, if we move to the second tier, now why we divide these into tiers? First of all, that the first tier platform therapies, they are there for a very long time. We have a very good record and experience available with interferons and glatiramer acetate. So we know that more or less that these are the least toxic therapies, and the cost is also not substantially high. Specifically, especially for teriflunomide, when we have the generic versions also available, so we can provide and we can offer disease modifying therapy now to a number of people with MS. So as we move up the ladder, as we go up the pyramid, not only the cost goes up, but also the side effect profile. What's most important that when we move up the pyramid is the effectiveness. So if we call as the effectiveness of the platform therapies, if we say that glatiramer acetate and interferons, they are of the tune of 40 to 50% of effective in reducing the relapse rates, annual relapse rates, and the effectiveness up to the 70 to 80% in the MRI activity, whereas teriflunomide is slightly better than has been shown to be in the clinical studies to be better than interferons and glatiramer acetate. So we move up the tier. In the second group, we have the oral dimethyl fumarate, and which is an oral capsule to be taken twice a day, and we have the options of now many upcoming highly effective therapies which can be offered in this subgroup. Now fingolimod jumps between second and the third tier. Many times you can also offer fingolimod to these people. It's a once daily capsule started in the hospital settings usually, and because of the first dose effect on cardiac rhythm, so needs cardiac monitoring for the first 24 hours. Then is the last, that is the tip of the pyramid, where we have very highly active therapies as compared to the second tier, which has an effectiveness to the tune of 50 to 60% in around 60% in reduction of annual relapse rate, and 80 to 90% reduction in the MRI activity, new MRI activity. The highly effective therapies, which include, as I told you, oral fingolimod is also one of them, and the other is the natalizumab, which is available for now quite a good time, and we have the option of alemtuzumab, The fungolimod, I told you, it's a once daily capsule. The natalizumab is a every 4 weekly 28 days infusion, can be given as a daycare injection. And LMTuzumab usually is what we consider as the immune reconstitution therapy. It's a 5-day infusion therapy, like 5 injections in the first year and 3 injections in the next year. And around 66% of the people don't require the third injection. The other therapies which are available in the highly active ones are the autologous hematopoietic stem cell transplant, which is again an upcoming therapy, and obviously it is performed in coordination with the bone marrow transplant team, and it's a autologous hematopoietic stem cell transplant, so your own cells which are harvested, stem cells which are harvested, and they home as your immunity. Again, this is a type of immune reconstitution therapy. Now, what to look for? What are the common side effects of disease modifying therapies? The safest and the most well tolerated is the glatiramer acetate. Usually, being a subcutaneous injection, it has got some local site reaction, which are the most important ones, and it's a peptide, so it doesn't interfere usually much with your body homeostasis. So it's the most convenient and well tolerated one. And I also highlighted the fact that it's one of the first DMT in people who have an active multiple sclerosis. Females can use this product, continue to use this product in pregnancy also. Now, the interferons, they are one product which usually are responsible for the side effects when you get a flu. So if administered, they can have, other than the local reactions, very commonly, especially in the initial injections, when you start with those interferons for 24 to 48 hours, you can have flu-like symptoms like body aches, myalgias, and a feeling of fever. So we usually administer it with paracetamol, and as you continue with these interferon therapies, you start tolerating them well, and we usually give the once weekly injections and fortnightly injections on the weekends, when the person can take adequate rest and keep hydrated and can tolerate and just can tide over that initial flu-like symptoms. The other thing which we need to monitor is the liver function test. And coming to teriflunomide, again, the most important thing which we need to look at is the liver enzymes. And so some people report hair thinning, but grossly there is no hair fall. The other aspect which with the teriflunomide I highlighted yesterday also was the issue of teratogenicity, which was seen in the animal studies. So females of childbearing age and those who plan to conceive are definitely a big no to the use of teriflunomide, and even the males who wish to father a child are big no for teriflunomide. So dimethyl fumarate, it's a very highly effective, very convenient dosage. It's a twice a day capsule, and usually the common side effects are the GI side effects. You can have nausea, abdominal cramps, and the other side effects are sometimes flushes, and you need to obviously monitor the liver enzymes and the CBC, that is the complete blood count. Coming to the fingolimod, I have already told you the first dose effect on the cardiac rhythm. So the initiation is usually done in the hospital settings. You administer the first dose under cardiac monitoring, and you monitor the patient for at least 24 hours post first dose. And the other things which we need to look at is the lymphocyte count, and because the mechanism of action of fingolimod is such that it sequesters the lymphocytes into the peripheral lymphatic system, and you can have a low lymphocyte count. So you need to monitor, and depending upon the grade, WHO grade of lymphocytopenia, you have to either withhold or to stop or to switch the drugs. Now the natalizumab, I think this is something which changed the paradigm and the way we approached multiple sclerosis, because it was one of the first highly effective therapies which was available to all the neurologists across the world, and most of the people had a very good experience. But the challenge, the convenience was definitely the once every 28 days 1 hour infusion without major infusion related reactions. But the challenge was, which emerged initially with 3 cases which were reported of PML, progressive multifocal leukoencephalopathy, which is opportunistic infection due to the decreased immune surveillance that happens in the CNS due to use of natalizumab. And this is a JC virus infection, which is a very ubiquitous type of virus, but gets reactivated when one is on natalizumab. So it was reintroduced with a very rigorous patient monitoring system, and a program is in place to rigorously monitor the JC virus index in the serum, and from the antibody status from the outset when you plan to initiate natalizumab. And what has been established over the period of time is that you can safely use natalizumab if the titers are, your antibody titers are quite low, your JC virus index is low, and up to at least 2 years. And with people who have rising titer and go beyond a certain point, when your neurologist can decide either to switch to a safer alternative or the decrease the interval, just increase the interval between the dosing, or now we which is now has been proven to reduce the chances of PML. And the other thing is to increase the surveillance by either doing MRIs or especially again reducing the interval between the testing of the JC virus index. Now these all risk mitigation techniques for PML have been found to be quite effective, and with the recent evidence from the NOVA study suggesting that increased interval has been found to be more or less similarly in efficacy, and with the significant reduced risk of PML thing has to be basically replicated in the real world, and we need to have yet to receive a good answer in the real world. Coming to alemtuzumab, I told you this is an immune reconstitution therapy. The major challenges with this infusion is definitely the cost. It incurs a substantial cost, but it's a very convenient 5-day injections which one can receive in the first year, which needs to receive in the first year. Then one can go. There is 1 year. You just need to monitor the not only the cell counts but also the any development of thyroid dysfunction because of autoimmune thyroiditis, and very importantly you have to look for development of any other immune mediated either ITP or nephrotic syndrome, that is a kidney issues. So with the help of urine analysis, any presence of proteins in the urine, then there is a risk of reactivation of varicella. So you can have what we give usually prophylactic acyclovir post alemtuzumab, and we need to monitor for a special type of opportunistic infection which is called as listeriosis. So there is a restriction for the use of dairy products for at least for the time you are on alemtuzumab therapy and 4 months thereof. Similar is the case for the pregnancy. Alemtuzumab, the pregnancy can be planned after the 4 months of the second course, which just constitutes of 3 injections. And talking about autologous hematopoietic stem cell transplant, it's available at a very restricted number of centers, and very recently a positive trial has been reported for its use, especially in people who have an active RRMS, because in RRMS till now what has been targeted is the evidence of active inflammation. That is the target of the therapy. But with the change in the concepts and understanding of what contributes to actual progression, that is the neurodegeneration, work is on for, and data is being looked at and subgroup analyses are being done to understand which therapies actually give benefit in the terms of reducing the neurodegeneration and thus helping people with MS delay or to halt their progression. And that's the most important target I personally feel is pertinent to clinical practice as well. So the therapies in the topmost tier are effective to the tune of more than 70% in reducing the annualized relapse rates, and to the tune of 90 to 97% in reducing the new MRI activity. We do have what we call as the anti-CD20 B cell depleting therapies, and with the upcoming role of B cells in not only the progressive phase of multiple sclerosis, where you have ocrelizumab, one of the drugs which is the only approved therapy till now for the primary progressive MS, and I told in the first video, which is the progression from the outset, and it can happen with or without activity. So ocrelizumab is the only therapy which has been, it's an anti-CD20 B cell depleter. It's a infusion which usually is given 6 monthly. So in countries where ocrelizumab is not available like India, we do use rituximab for not only for people with primary progressive MS, but also with people who have evidence of progression and in people who don't tolerate but need highly effective disease modifying therapies. So again, rituximab is a 6-monthly infusion therapies with slightly less robust data for its effectiveness in people with MS as compared to other immune-mediated inflammatory CNS demyelinating disorders. We have ample experience, and there are good papers which have been published from India about its tolerability, efficacy, and cost effectiveness. So we have other therapies like oral cladribine, which can be again are very low frequency, similar to alemtuzumab, and very high therapies, but they are quite toxic, and moreover they are not available in India. It's available in US and Europe. So again, lymphopenia is a very important issue, and we have an upcoming highly effective therapy, a very less frequent one, ofatumumab, which is a completely humanized monoclonal antibodies against the CD20 molecule. Again, it's a B-cell therapy, but it would be a subcutaneous injection which can be self-administered every month. So hopefully that will be available in India shortly, and will be another shot in our armament, and another thing which will be available to us to be offered to our people with MS. This post is really long because this is an extensive issue, and I think if we talk these days about personalized medicine, then disease modifying therapies in multiple sclerosis are the best example which one can quote for this entity. And so not only the initiation of disease modifying therapy, so the selection at that particular point is important, but a continuous monitoring is something which every MS physician and neurologist has to do, and the person with MS should also be aware of the common side effects and should be very regular with the monitoring, and should assist their MS physician, their MS nurse in highlighting and bringing all those common side effects when they are on any particular disease modifying therapy early on, so that the risk can be mitigated and things can be really steered in a very effective and convenient way. Then there is some question of switching. I think this is something which is a very specialized job, but what you need to understand that in people who are on effective disease modifying therapy, if their disease still behaves very I would say aggressively by indicated by accrual of disability, which is due to the high disease activity leading to a lot of physical and cognitive disability, and especially in the past 1 year. So we'll discuss that. But so the pyramid should be flipped in these cases, and they should be offered highly effective therapies early on. The issues remain the more common side effects and significant side effect profile and the cost. So, but in long term, I would say that this proves to be more effective, because as you control the disease, you are ensuring the health of and a life without disability, promoting that, and it translates into good quality of life. And in long run, quality of life as well as the cost effectiveness is seen in use of highly effective therapies early on also. So there is something called as induction and then maintenance in these people. So goodbye for now. Hope you find it useful. Please like, share and comment, and see you tomorrow.